Hi, good afternoon, everyone. This is Mark Eyre with Brightsquid. Thank you so much for joining us this afternoon for our series on improved patient outcomes. Today's presentation will not be hearing from me as much as normal or my colleague Jeff. We're actually very honored to have a guest speaker today that I'll be introducing here in just a moment. I have a couple poll questions. So today's conversation is all around relational healthcare and how that works within your clinic. So I'm going to post one of our poll questions here, and we'll get a couple of answers there, and we'll see where everyone is in terms of their relationship model. The poll should be presenting on your side now. We'll give us a couple more seconds to run, and it looks like we had about a 75% agree on that conversation, so that's great. So now I'd like to introduce our guest speaker. We're honored to have Beth Kidd, Executive Director of the Alberta Coalition of Alberta. I'm not going to read through Beth's entire extensive and impressive bio here, but it's on the screen there for everyone to see. We've asked Beth to come to talk to us today about the relational model of care. Sorry about that, I kind of fumbled my words. Beth, in a moment here, I'm going to turn the microphone over to you. But for now, I just wanted to show your bio. A couple of key things to note here is volunteer work with the Research Canada's Board of Directors, Canada's Drug Agency Patient and Community Advisory Committee, and some other things as well. A little bit about the Health Coalition of Alberta and its goals and visions. Again, I hesitate to read every word on the screen, but I do want to read this quote. We envision a healthcare system where all Albertans have an equitable voice and access to services needed to achieve their full health potential. This is absolutely a vision that Brightsquid fully supports and agrees with and aligns with. So we're very happy to have Beth here today to tell us a little bit more about how all this works and her vision for moving healthcare forward here in Alberta. I'm going to make you the presenter now, Beth, which will allow you to share your screen and your slides.
Okay, I'll zip through some of these then. So
Thank you very much.
and some of them you've already covered off, but I do wish to acknowledge, first of all, that I'm speaking to you on the land that is located within Treaty 7 and the traditional territories of many First Nations, including the Siksika, Kainai, Tsuut'ina, Stoney Nakoda First Nations, and of course, Calgary is also home to the Métis Nation Region 3. As a provincial coalition, we acknowledge those whose footsteps have marked these lands for centuries, and we also support and advocate for the Truth and Reconciliation Commission of Canada's 7 health-focused calls to action. And I would encourage you to Google that if you don't know what those are and learn more for yourself. So just kind of in the interest of time, as a quick overview, I did want to kind of give you a sense of who we are at the Health Coalition. We are an independent, volunteer-driven, virtual nonprofit society focused on patient advocacy. Our members are primarily health charities and patient groups, but about 25% are individuals. And actually, our membership base makes us one of, if not the largest of this type of group in Canada. So here's just a quick, colorful slide of our board of directors showing you some of the faces of who guides the governance of our coalition. Mark already talked about our vision for healthcare in Alberta, and there's a bit of a flag there. You can see if you go to our website, you can dig a little deeper and look into our strategic plan. But certainly, I wanted to highlight the goals of our strategic plan. And as you can see, promoting a relational model of care is called out as a standalone goal for our organization now. It was modified, some of our past work, I would suggest, has been modified in this current strategic plan and given more direction around relational care. Obviously, patient engagement, health equity are, very foundational pieces for us as well. And actually, access to medications and medical devices has been something that our members have set as a priority since we were created in 2006. So our approach is primarily focused on systemic advocacy. So we are looking at the big picture and trying to bring about broad system changes that impact all Albertans and for sure all of our members. We work with our members to find common ground. They're very diversified. We don't have any solid membership base in one therapeutic area or even one age group. It's across the board. So we look for that common approach that will impact the healthcare system in Alberta and actually Canada as well. We do get involved on federal issues when we think there's an opportunity and a need to bring Alberta's perspectives forward. We are a collaborative advocacy organization, so that means we are looking at trying to work with a wide variety of stakeholders, if not all stakeholders, on a particular topic or issue, and we're trying to find a solution that will work for the majority of them. And as I said, patient engagement is very foundational for our approach. We definitely value and promote lived experience. We talk about patients being co-developers now of healthcare decisions, and we certainly encourage balanced representation if organizations are moving towards that patient engagement model. So what I'm here to talk to you about is a relational model of care and what we mean when we talk about that. So this is our statement. We have a backgrounder. We've done a fair amount of work over the last, I'd say formally at least 5 years, if not, before that, we were already, making a shift in our positioning around access to care in the province. And so where we are today is that we recommend the adoption of a flexible relationship-based model that's focused on shared decision-making. And it is tied into, what is commonly talked about patient-centered care or person-centered care, but it's certainly moving beyond that. It's taking our existing task-based medical model that we have that's focused on diagnosis and treatment. The outcomes are focused on that treatment, and it's moving it into something that is much more encompassing, that focuses on the emotional and social needs of each individual, with outcomes determined by the patient and supported by the care team. So I'll be really interested after the end of this, looking at that poll that Mark did at the start, that I think it was 75% of people in attendance today said that they employ a relational model of care. It'll be interesting to see if you see alignment and if it, really supports what we are talking about from a patient perspective when we discuss relational care. I'm just gonna try and, I can't do that. So what do we mean by that? Well, it is a framework that recognizes the role of relationships and how it distributes power and choice among all participants of the healthcare system. And it certainly is a move towards changing the balance of power and shifting away from the preferences and values of the doctor to focus on the outcomes that matter the most to the patient. Care is based on individuals' needs, values, and preferences. And later on, I'll give you some examples of what I'm talking about here. A core component, informed and educated patients are co-managers of their healthcare decisions. There's equal participation when it comes to making treatment option choices, and those plans can oftentimes be produced not just with the patient, but also with their support team around them. So their caregivers, their loved ones, even people from their community or community programming can often come into play when we're talking about this type of a relational model of care. Another key component of this is that it provides time to listen, so that healthcare providers are actually funded and paid to have the time to listen and work with the patient to develop that co-designed treatment plan. Another big concept is that it integrates health and social care beyond the traditional boundaries that exist in Canada. We all know that there are silos between health and social services in this country, not just in Alberta, but in this country. Consistent care assignments are essential. It's tied to creating those long-term relationships between patients and their healthcare teams so that they are trusted and listened to and valued, on both sides, the healthcare provider as well as from the patient perspective. So as I'm sure you can see from what I'm talking about so far, collaboration, cooperation are essential values, as is compassion and empathy and respect. And certainly, 5 years ago when we first started talking about this, I definitely, got quite the reaction from everyone, quite frankly, everyone, healthcare providers, politicians, government staffers, bureaucrats across the board. This is something that requires a culture shift in the Canadian healthcare system. It needs education, it needs legislation to support it, there needs to be funding in place. But on the good side, on the positive side of this is actually not a new model, as some of you already know. We have international examples of where this is at play in different therapeutic areas, in particular dementia for sure, primary care, maternity care. There are some wonderful examples of the impact of that, but I would also like to point out that this relational model of care absolutely also applies to acute care. It may be a challenge when it comes to the emergency room department, but certainly when you look at our hospital system, it's beyond the ER, and relational care should be employed throughout, is our position. There's already lessons learned from Scotland, Wales, Australia that all focus on health outcomes, improved health outcomes, patient satisfaction, employee engagement, and of course, as I'm sure you can imagine, when it comes to the government, also about health system savings. So I pulled a few quotes for you here just to highlight some of the reported improvements and outcomes directly tied to moving to a relational model of care. Our Care is a continuing care organization in Australia, and in particular, they've used this approach in the dementia care space, but across the board with continuing care, but for sure in the dementia care space, there's been some pretty dramatic stories shared about the impact moving to a relational model of care has had for patients, for those people living with dementia, and reducing their frustration and potential anger about their position. And this is one from Wales, again, talks about how there are improvements that they have witnessed by implementing this model all the way across the board. And I will say this is actually my favorite quote. I always laugh, trust the Scots, to get right to the heart of it. What is essential is to eliminate silos and dismantle self-protective institutional or professional boundaries that impede flow and responsiveness. And I want to be very clear, that's not my language, that's their language. It's from this report, and it's repeated actually in a lot of the documentation that you can find through Scotland. So I wanted to talk to you about the patient experience when it comes to relational care and provide you some examples of that. So certainly, as I said, there was an example out of, I actually went to a session years ago with the Chief Medical Officer of Health from Scotland, who gave example after example, in her using her obviously delightful accent and, ingrained storytelling ability that I just don't have. But the one story that she told that I remember just really honestly popping my eyes. I was so shocked at this one. It was about, a lot of this does come down to seniors care. And it was about an elderly man who was living at home, independent, and was presenting, unfortunately, many times with respiratory illnesses. He ended up with pneumonia, and at that point, the discussion was like, maybe you shouldn't be living at home anymore. Maybe the time is to look into moving into a facility. And the system that they had in place at the time, anyways, actually meant that this triggered a home care visit, an assessment in his house, not by our view of home care, but by physicians, right? By a nursing team, by a community care team, beyond a healthcare aide. And they went to his house and did this, met with him there, and met with his family and his support group around him, and did an assessment. And they actually determined that the reason why this gentleman was becoming ill so frequently was because he needed a new roof, that the roof on his house was leaking, and he was living in probably damp and moldy conditions, if you think of Scotland. And that's why he was becoming ill. And so under their relational model of care, that medical team was able to, amazingly to me anyways, come back and connect through with social services, and actually the man's roof was fixed. They used public through the healthcare team to fix the guy's roof so that he could stay at home. And if you think about it, it checks the box on at every level. It means obviously tremendous quality of care and quality of life for the gentleman because he didn't want to move into a facility. He wanted to stay at home and he was otherwise independent. He just couldn't afford to fix his roof. From a system savings, the cost of fixing his roof versus public funding for this man to move into assisted living or into the continuing care system was, you can't begin to compare the dollars amount, right? The amount of money they saved by putting it into fixing his roof. But the uniqueness of this is, can you imagine that happening in Canada? I have certainly never seen that kind of a situation in my 25 years of doing patient advocacy. A closer to home example is during the last election, I went to a couple of events to try to gauge public interest in healthcare, or people talking about healthcare prior to our provincial election. And I went to one in my community at a coffee shop, and I was with people I didn't know anybody there, and nobody was talking about healthcare. So towards the end, I finally raised it, and the man sitting beside me started sharing this experience that he had just had. And he was in his 70s. He appeared to me as a trim, active man, but he shared with me that he has osteoarthritis in his hip and he's a low-income senior. And so he had booked an appointment with his physician to get a cane because he really felt if he just had a cane, it would help him to continue to get around on his own and cope with his arthritis. He was pretty clear in sharing the story with me that he was unwilling to have a hip replacement surgery, and he just didn't think he was there yet, and all he wanted was his cane. So he went to the appointment with his physician, and he left with like 3 or 4 referrals that all had him on the track for a hip replacement, as well as a prescription for stronger pain medicines, but no cane. So he had no intention of filling the medication prescription because he didn't want to change up his medications. He had no intention of doing any of the follow-up for all the referrals because he didn't want a hip replacement. He didn't want to start that process. And in fact, I connected him with a publicly funded program we have in Alberta that provided him funding to secure a cane so that he could continue living on his own. So it's another example of if you just could have made that connection in the first appointment that he had. Think of the system savings that would have been occurred, and think of the impact on this man's quality of life and his satisfaction. Instead of him complaining about it 3 months later to a stranger looking for suggestions on how he could get his cane, he would have had it for the last 3 months. So we are seeing some improvements in Alberta. I know we're kind of quickly running out of time here. Definitely we're seeing the impact of understanding more about a relational model of care coming through in the Continuing Care Act. It is set up to allow for patient choice. The client-directed home care invoicing program, that expansion across the province, is a prime example of relational care and the move towards understanding patients are co-managers of their health and should be making their decisions. We do see a lot of language in the proposals and discussions around healthcare reform that also tie back to a relational model of care, in particular with primary care. But we'll see this fall and what gets announced with the launch of the provincial health agencies and how focused that is. For sure, there's more and more discussion about team-based care and the need to modernize care pathways and the social determinants of health impact. I was at a consultation, and AHS actually posted a slide that said for primary care visits, 50% of family physician appointments are tied to social determinants of health, and only 25% are medical in nature. And so think of the impact. Think of that man who was looking for his cane. Should he really been talking to a doctor? Or should there have been someone else on that team that would have been more appropriate to have the conversation with them and actually refer them to the program that I ended up connecting them with? So I know I'm running out of time here really quickly. I do want to talk a bit about the importance of patient engagement. At the Health Coalition of Alberta, we talk about there being a spectrum of patient engagement, and it starts with if this healthcare decision has the greatest impact on patients, then there must be the highest level of engagement with patients. I just was in a webinar yesterday that we were talking about the environmental impact of access to medications and the need to move towards shorter prescriptions so that patients could try out the medication and you know that it doesn't trigger wastage in the system. But let's talk about the impact on the patient. What if you lived on in a remote community, and the fact that you have to go back into your pharmacy a week later just to get the rest of your medications, and the environmental impact of all that, let alone the societal impact. But I did love this quote because it does talk about what happens when you do not include patients in these decisions. So this is a quote from someone in England who talked about a community partner, so a patient, who was talking about what it was like to be told what the problems are for your community and to be told these are the solutions. And his point was, if we wanted a unicorn, we would have asked for a unicorn, but what we wanted was a dentist. And if you move to a relational model of care, you would have made that connection. So we very quickly here have 3 recommendations that we talk to government about. One is that healthcare reform must include patients as co-developers. We obviously encourage the support of a relational model of care that's centered on patient needs so that Albertans can achieve their full health potential. And this model has to include shared decision making between healthcare teams and educated and informed patients so that it creates opportunities for the individual to make the choices that will have the most impact on their health, emotional, and social needs. So I can't believe I somehow managed to rip through that with 2 minutes to spare, but I did. I hope I didn't go through it too quickly. I hope what I have presented resonates with you, and ideally, in a perfect world, that you see what I've talked about from a patient perspective at play in your practices. But I guess, Mark, I'll hand it over to you to moderate any questions.
Yes, thanks very much, Beth. Thank you for your presentation and for your time today. I'm just going to switch the screen broadcast back over to my side. But while I'm doing that, I actually had a question that came up when you were speaking. You talked about when your coalition was first proposing this relational model, and you kind of alluded to some of the reactions that you received then. I wonder if you could elaborate on what some of those reactions were like, for better or for worse.
It was a lot of kind of incredulous reaction. You're asking for what? And it really stemmed from the massive shift that our healthcare system would need to undertake to move to a full across the board relational model of care. And also, I had a lot of people say, and I still do, get a lot of reaction of, yes, we understand what relational care is. And then when I ask them to describe it, they're not talking about what patients are talking about and what patients are expecting, quite frankly. I try to say, you know, if you think I'm a demanding or I'm a handful or I expect to be considered as a co-manager of my health, you just wait till my daughters come into your office and see what their generation is going to expect in terms of, you know, understanding that it's their health and it's their life, and they most definitely share in making those decisions. So I think, though, in you know, let's say 5 years time, I think there definitely has been a shift to understanding. I don't get as many people making assumptions about what we're talking about. And I don't get as many people automatically saying, yes, we already do that.
So the model is really driven by kind of patient desires and you know, those expectations.
Yes.
Okay, fair
So
enough.
people have changed, right?
Yeah,
and
yeah,
and you know, we've shifted quite, you know, if you look at various generations, you look at, you know, my mother who is 85 and absolutely, you know, expects her physician to tell her what to do. But my mother has dementia. And so when I'm in an appointment with her or when my siblings are in an appointment with her, it's a very different discussion and an expectation that we're making joint decisions, let alone for my own health or, as I said, my daughter's.
for sure. Okay. Beth, is there anywhere that you would like people to reach out or go to find out more information about your coalition and the relational model?
You certainly can go to our website. I'm pretty sure we have our
Yeah.
background on a relational model of care on our website. You can also contact me directly, which I think was on my last slide. But you can find my contact information on our website actually.
And that's
Um,
this website here,
or
the
look at,
healthcoalitionab.ca.
yeah, and look at some of these examples of where this model is in place already, and read some of the past reports on what remarkable change it has brought about.
Excellent. All right. Well, that is our time for today. I wish we had some more time today. I think there's a lot more questions we'd like to have asked and answered, but I'm going to wrap things up for now and say thanks again for everyone for joining us. And Beth, thank you so much for taking time out of your schedule to speak to our group today. Have a great afternoon, everybody.